Hello, everyone, and welcome to today's NIH Collaboratory Grand Rounds. I'm Leslie Curtis from the NIH Collaboratory Coordinating Center here at Duke, and I'm really pleased to welcome today Matt Semler and John Casey, who will be from Vanderbilt, who will be talking to us about embedded pragmatic trials in emergency and critical care. Really timely topic. So, Matt, with that, let me turn it over to you.
Well, thank you so much for having us, and thank you for the NIH Collaboratory with the CoreNet for inviting John and I to come talk with you today about embedding pragmatic trials into emergency and critical care. We want to start by thanking the NIH and PCORI. Everything you hear about today was supported through their generosity, and so we appreciate their support. So the context for today's talk is the clinical care of critically ill adults. John and I are both ICU physicians, and I spent the last week on service, and every time I'm up in the ICU caring for critically ill adults, I'm struck by how many decisions we face as clinicians in everyday practice where we're choosing between two available therapies and we have no data on which to know which is right or best for the patient in front of us. And this has always kind of been the defining thing to me about emergency medicine and critical care. And so even as a fellow, I made this slide, which was the three most common things we do in the ICU. Three of the most common things are mechanical ventilation, administration of IV fluids, and tracheal intubation. And these were all the decisions at the time that I felt like we had to make almost on a daily basis, that there had never been a randomized clinical trial to guide knowledge of what would result in the best patient outcomes. And so for mechanical ventilation, simple things like which mode should we set the ventilator on? For IV fluids, the most common therapy for hospitalized patients, simple choices like which fluid and how much. And then for tracheal intubation, when I started fellowship and we started thinking about these things, there had been a total of 2 ever randomized clinical trials in tracheal intubation of critically ill adults, and it just drove me nuts that we had to make about a dozen decisions during this procedure, which might have real consequences for patients, and had exactly 0 data on which to base those comparative effectiveness decisions. So John and I have started to obsess over how do you rigorously compare the effectiveness of available interventions during emergency procedures and the provision of critical care, and what are the barriers that are preventing us from having that data to know what's best for patients. And we've identified and are going to talk about today 4 barriers that I think are important to generating comparative effectiveness RCTs to inform the care of emergency medicine and critically ill patients. And each of those has kind of 3 characteristics. One is, what are the characteristics unique to the emergency medicine or critical care environment? And how do those characteristics get in the way or challenge traditional RCT procedures? And then what are some potential solutions that we've used or others have used that might help address that challenge and crack open the field of comparative effectiveness research for emergency procedures and critical care? So the first of these challenges that John will talk about is the brief therapeutic window that for many critical care procedures, they occur over the span of minutes, not hours or days. And so how do you conduct screening, enrollment, randomization, and delivery of an intervention in the minutes before an emergency procedure? And with a potential solution John will talk about is embedding each of those RCT procedures within the people and systems of clinical care that are already present at the emergency procedure and help facilitate that work. The second that I'll talk about, is that for patients experiencing critical illness, there's often a mix of acute and chronic comorbidities that can influence the outcome outside of the disease of interest or the disease being targeted with the therapy, and there's a limited time for patient phenotyping. And together, those combine in some cases to be trying to detect very small treatment effects, so a needle in a haystack with a lot of other noise going on, which can require sample sizes that have historically been prohibitively large for this type of research. So if we're comparing two common therapies and even small differences matter, how do we leverage information technology tools and the electronic health record and not just collect data on the back end, but facilitate each of the steps of an RCT to be able to do very large trials efficiently and inexpensively. Third, John will talk about what is kind of the classic issue that you might think of as a barrier in emergency and critical care research, which is the lack of decisional capacity in surrogates present during a lot of these procedures, and how that reflects on the informed consent process, with a specific discussion of EFIC, waiver, and the gray space between them as it applies to comparative effectiveness, RCTs, and emergency procedures. And then finally, I'll briefly talk about something that I think is a huge issue in this space, but is underdeveloped, which is that we know patients respond differently. Different patients respond differently to the same therapy, and yet historically our trials and others in this space have presented average treatment effects and have not had the sample size or the statistical methods needed to get to understanding treatment effect for individual patients, and how we might make progress towards that goal. So over the next 30 minutes, leaving plenty of time for discussion, we're going to talk about each of those 4 challenges. So John, do you want to talk to us about the brief therapeutic window?
Yes, thanks, Matt, and thanks to the NIH Collaboratory for the invitation today. So this will be the topic of the next few minutes, and we're going to talk about this in the context of tracheal intubation. Tracheal intubation is where we've done a lot of our work. Emergency tracheal intubation is an extremely common procedure. It occurs to between 2 and 5 million adults each year in the ED and ICU. The vast majority of these patients are comatose or delirious, and up to 5% during cardiac arrest at the time of procedure. In addition to these barriers to consent, the therapeutic window for the procedure is extremely short. So there's a median of 5 minutes between the time that we decide to intubate a patient and the completion of the procedure. But how do you conduct an entire clinical trial in that short period of time? Further, emergency tracheal intubation is a space for which we critically need data to improve the care of patients. For healthy adults undergoing elective procedures in the operating room, complications during intubations occur in no more than 2% of cases. By contrast, intubations in the ICU and ED experience hypotension, hypoxemia in up to 40% of cases. A really striking number when you think about this as a 2-minute procedure. And because of the lack of data from comparative effectiveness trials, a huge range of practices has developed in the way this procedure is conducted across the country. And within this 2-minute procedure, there are a number of decisions, and none of these decisions have had evidence to help guide providers. Those decisions have included the type of device used to provide oxygen before the procedure, the medications used for the procedure, the approach to oxygenation and ventilation during the procedure, the equipment used to obtain a view of the glottis, and the approach to passing an endotracheal tube. And we're going to focus on a trial that we conducted on this middle step between the administration of medication and the initiation of laryngoscopy. Emergency tracheal intubation has this inherent delay of 45 to 90 seconds from the time that you administer medication until the patient is sufficiently relaxed to begin the procedure. And during this period, a patient's breathing slows and stops, and the risk of hypoxemia begins to increase. And for the last 50 years, there's been this ongoing debate about whether or not to provide ventilation during this interval. And this debate has continued because of opposing hypotheses. Bag mask ventilation may prevent hypoxemia, but it might also cause gastric insufflation and harmful aspiration. And the difference in the way that bag mask ventilation is used breaks largely along specialty lines. Anesthesiologists have historically provided bag mask ventilation to the majority of their patients, prioritizing a prevention of hypoxemia, whereas emergency medicine providers have avoided bag mask ventilation, prioritizing the prevention of aspiration. We conducted the PREVENT trial, the Preventing Hypoxemia with Manual Ventilation during Endotracheal Intubation trial, to compare those 2 approaches. It was conducted at 7 intensive care units in the United States. All adults undergoing tracheal intubation with sedation were eligible, except those who were pregnant, prisoners, or for whom the provider felt bag mask ventilation was required or contraindicated. Patients were randomized 1-to-1 to bag mask ventilation or no ventilation, and the delivery of the intervention and data collection were embedded within routine clinical care. So to provide a little more details, how do you do that? So you've got this 2-minute emergent procedure where any delay can be harmful for patients. How do you embed every step of a clinical trial in that short 2-minute procedure? And I think the answer is that you design it from the ground up alongside proceduralists to obtain really efficient trial procedures that won't delay their clinical practice. And how we did it for this specific trial question was strategically placing randomization envelopes in locations that would be convenient for operators, usually adjacent to airway equipment, using broad eligibility criteria that, in addition to providing generalizable results, would also allow operators to rapidly screen for eligibility and make decisions regarding eligibility within seconds. We use very simple intervention instructions, and we pared our data collection down to the bare essential elements that were needed for understanding the trial question and which could be conducted during this brief interval. And we ensure that those data elements were collected by clinical team members who were present but did not have a role in the intubation. And the identity of that person could vary by center. At some centers, that was another physician who was not performing the intubation. At some, it was a pharmacist. And in our center, it was our charge nurses. It had to be someone who was intimately familiar with the procedure, understood the outcomes that were being measured, but wouldn't be pulled away or distracted by clinically performing the procedure. And then the research team provided daily feedback on adherence to study procedure and data quality. Using these study procedures, we enrolled 401 patients. Their baseline characteristics are shown here by group. You can see they're well matched with a median age of 60, and the majority of patients had at least one risk factor for aspiration. Despite these very pragmatic study procedures, adherence to group assignment was excellent. All but one patient in the bag mask ventilation group received bag mask ventilation, compared to only 5 patients in the no ventilation group. So after 50 years of controversy, how effective was bag mask ventilation in preventing hypoxemia? It turned out it was very effective. It cut the rate of severe hypoxemia in half and was even more effective in preventing more severe cases. Further, there was no evidence that bag mask ventilation increased the incidence of aspiration. Operator-reported aspiration occurred in 2.5% of cases in the bag mask ventilation group, compared to 4% in the no ventilation group, and there was similarly no difference in the incidence of new infiltrates on chest x-rays post-procedure. So in summary, the PREVENT trial attempted to evaluate this ongoing controversy for 50 years regarding the role of bag mask ventilation during a very common procedure that was performed 2 to 5 million times per year, during which only about half of patients had been receiving bag mask ventilation. And in 1 year, at only 7 centers, we were able to run this very efficient pragmatic trial that definitively answered this question, that bag mask ventilation halves the risk of severe hypoxemia without affecting aspiration, findings that have really changed clinical guidelines in a lot of settings. I'm going to turn it back over to Matt, who's going to discuss our next challenge for conducting emergency and critical care research.
Yeah, thank you. So I think John talked a little bit about the acuity component about this. This next section addresses one of the next challenge, which is that when comparing two commonly used interventions that have been in practice for a long time, there's not always going to be a huge difference, in that you might be attempting to detect relatively small but clinically meaningful differences between groups in the context of a lot of noise. So are there information technology tools and ways to leverage the electronic health record that can gain efficiencies and dramatically increase sample sizes to allow us to understand these small differences in treatment effectiveness? So the example we'll talk through in this domain has to do not with tracheal intubation, but with IV fluids, the most common therapy received by hospitalized patients. And for more than 100 years, there have been 2 basic choices of IV fluid: so-called balanced crystalloid, like lactated ringers or plasmolite, and saline, which is 0.9% sodium chloride. And around 50 million patients a year receive one of these 2 basic types of fluid, but they differ substantially in their composition, in that chloride has 154 millimoles per liter. Saline has 154 millimoles per liter of chloride, which is about 50% more than human plasma, whereas lactated ringers and plasmolite and other balanced crystalloids are designed to have a chloride content that's similar to that in plasma. And for 3 decades, we've known that administering saline causes hyperchloremic metabolic acidosis. There have been concerns about whether it causes kidney injury, inflammation, but it had never been evaluated in a randomized trial. And so every day we chose between these fluids. And again, the decision was largely cultural. Internal medicine physicians tended to use saline, surgeons and anesthesiologists tended to use balanced crystalloids. So we wanted to tackle this challenge, but understood that doing so would, the difference here, if there is a difference between these fluids, is going to be a 1% or 2% difference, not something that's detectable with 400 patients like PREVENT or a smaller trial. So this, we're thinking about scale. So we designed the SMART trial as a cluster randomized multiple crossover trial. By that I mean that each intensive care unit, all of the patients, all of the nurses, all of the physicians were assigned to one of the fluids for a given month. So medical ICU is assigned to saline in June, to balanced crystalloids in July, to saline in August, and so forth. And this cluster design had several rationales, but one of the important reasons for it was it allowed coordination of the fluid being given in the ICU, the fluid assigned to the ICU, with the fluid being given in the emergency department and operating room prior to ICU admission. So instead of a trial design in which a patient with sepsis shows up to the emergency department, gets 3 or 4 liters of saline, gets to the ICU and is enrolled and randomized to the balanced group, having already received mostly the non-assigned crystalloid, from the very first drop of fluid as part of resuscitation in the ED, patients were receiving the assigned crystalloid under this design. Delivery of the intervention was embedded within clinical care, and what that meant for this trial was that the assigned crystalloid was stocked in the medication dispensing cabinets, and an advisor within the electronic order entry system informed providers about the study and either steered them to order the assigned crystalloid or to select one of the pre-specified contraindications to the assigned crystalloid. And in this trial, information technology tools in the electronic health record identified eligible patients, enrolled and helped with the delivery of the intervention, and collected all of the data on the back end. So over 2 years, this trial enrolled 15,802 patients, half of whom were assigned to the saline group, half to the balanced crystalloid group. And the patients in the balanced crystalloid and saline groups were similar at baseline, but they were also extremely representative of the patients that we care for in practice. Despite the use of the information technology tools and the novel trial design, patients in the balanced crystalloid group largely received balanced crystalloid, whereas patients in the saline group largely received saline. And to my surprise, as an internal medicine physician who had always historically ordered saline, what we observed was what the study hypothesized and was powered to detect, which was about a 1% difference between groups in the absolute risk, the primary outcome of death, renal replacement therapy, or persistent renal dysfunction. So that's a number needed to treat of about 100 for therapy received by about 50 million patients a year. We are emphasizing, obviously, in this talk, the need to understand things not just in the ICU, but in the emergency department. And so we conducted, in addition to that SMART trial, which focused on critically ill adults, we collaborated with Wes Self and our other collaborators in the emergency department to conduct a parallel trial among around 13,000 patients presenting to the emergency department who needed IV fluid but were not critically ill. And in that non-critically ill patient population, we found the same 1% absolute risk reduction in death, new renal replacement therapy, and persistent renal dysfunction in favor of balanced crystalloids over saline. So methodologically, there are strengths to this, right? So setting out to detect a 1% to 2% difference in an outcome for therapy received by millions of patients is somewhat new territory, and using the information technology tools to conduct every aspect of the RCT is an advance in that, but this is only done at one center, right? This is a huge limitation. And to be transformative, these approaches, we must have information technology tools that must be freely available to connect an EHR directly to a study database and facilitate each step of the RCT in a single, simple to use package that can work at any center with any electronic health record. And so our current proposal, our grant submission to NCATS focused on this, that has 2 halves, one of which is on the movement of data from any electronic health record at any center into REDCap and back. And this is the EHR to REDCap integration that uses FHIR resources and APIs to transfer data in and out of electronic health records for Cerner, Epic, agnostic, and vendor. And the second half is not just to get data, but to use that data to facilitate all of the 10 basic steps of an RCT. So using the electronic health record data into REDCap to help with screening, eligibility assessment, the REDCap e-consent tool to be able to communicate with patients and clinicians remotely to facilitate consent, randomization, etc., throughout the entire 10 steps of a clinical trial. So I think our hope is that as this develops over the next 4 to 5 years, this would be a free, generally usable tool that could help make more efficient and inexpensive the use of information technology and electronic health records to conduct large comparative effectiveness trials in emergency and critical care. And I'll hand it back over to John to talk more about the informed consent process, which is the third challenge.
Yeah, so we talked in the beginning about how hard it is to conduct a trial during these very narrow therapeutic windows. And we also alluded to the second challenge, which is how do you obtain informed consent when patients lack decisional capacity, they're delirious or comatose, surrogates may be unavailable, and more importantly, the therapeutic window is so narrow that consent is infeasible. So we're going to talk in this section about what the guidelines currently prescribe for that and what some challenges are. So here's an overview of all of the current regulations for informed consent. And in this paradigm, risk to patients is on the y-axis, with things at the top half of this figure being those that represent significant risk to patients, and those at the bottom half representing no more than minimal risk to patients. The x-axis represents the ease with which consent is obtained. Things in the far left, consent is practical. Things in the far right, which is what we're talking about largely today, are questions where consent is impractical. And regardless of the risk to patients, when consent can be obtained, it's obtained in traditional research. The challenge is the cases that we're talking about now, consent's impractical, and there are two types of regulations that apply to that work: exception from informed consent for emergency research, EFIC, and waiver of informed consent. And waiver of informed consent applies to research that's no more than minimal risk, for which the best example is observational research. So we're going to talk a little more in the next few slides about EFIC. So EFIC was implemented in 1996, and it was designed to allow research in a space where it had previously not been able to be conducted. And so prior regulations didn't have any way in which you could conduct a randomized trial if patients couldn't provide consent. So EFIC was designed to solve that challenge, and it was intended to demonstrate transparency and respect for persons in the absence of prospective informed consent. And it specifically focuses on conditions that are immediately life-threatening, for which existing treatments are unproven or unsatisfactory. And it's intended to cover this research that represents more than minimal risk to patients. And there are many components of EFIC, but we'll highlight two components that were the most distinct and different from traditional consent. Because prospective informed consent cannot be obtained, EFIC requires that before trial initiation, the investigators must perform community consultation and public disclosure. So what are those, and how long do they take, and what do you do? So community consultation is this two-way communication through meetings like town hall meetings, focus groups, one-on-one meetings, and these provide the opportunity for affected communities to learn about the study and provide meaningful input to the IRB before study approval. Public disclosure is a one-way communication, press releases, radio, newspaper, and social media advertisements. And the goal of public disclosure is to inform the community that this trial is going to take place and to be maximally transparent. I think these are really important and noble efforts that are particularly important when you're doing a trial that's going to present new risks that wouldn't be experienced in traditional clinical care, things like new drug and device studies. But it is notable that the cost and duration of these are significant. It's estimated that the time duration to complete community consultation and public disclosure is between 1 and 3 years, and the costs are approximately $50,000 per site. So if EFIC is intended to help us conduct research in the emergency and critical care space, how is it doing in that regard? In the 20 years after EFIC was implemented, there were 41 trials conducted. And of those, the majority were new drug or devices trials, for which I would argue EFIC is working extremely well. I would highlight that what we're talking about today are largely comparative effectiveness trials. Trials comparing things that patients are already receiving in usual care, standard of care interventions. And EFIC, the minority of trials in EFIC have focused in this area. Only 14 trials in 20 years, less than 1 trial per year. And I think it's important to compare that to what research that's been going on during the COVID pandemic. So in COVID-19, in the 2 years of the pandemic, there have been more than 11,000 trials focused on COVID-19. I think that when you compare that to the 14 trials of comparative effectiveness research under EFIC, I think it highlights concerns that the burdens of community consultation and public disclosure might be preventing potentially beneficial research for patients. And I also want to come back and highlight that there are some gaps in the current regulation for emergency and critical care research. EFIC is explicitly meant to cover conditions that are immediately life-threatening. But there are very important and urgent research questions in emergency critical care for which consent is impractical, but the underlying condition is not immediately life-threatening. Some examples include alcohol withdrawal and acute agitation. There are those who've advocated that when you're comparing standard of care interventions, that represents no more than minimal risk to patients, and therefore some comparative effectiveness trials are conducted under waiver of consent, but the regulations provide very little guidance on how that minimal risk assessment should be made and whether or not this is an appropriate use of waiver of informed consent. And those gaps we call the gray space and are focused of an ongoing U01 from two of our collaborators. So in the absence of data from comparative effectiveness trials, what occurs in clinical care now? So let's imagine you have a common condition with at least 2 available therapies. When a patient presents now, if there's evidence for one therapy being superior, it's easy, the patient gets that therapy. When there's no evidence of superiority, a decision still has to be made. And in current clinical practice, that decision is made arbitrarily. And we talked about that in Prevent and SMART. And my prior use to Prevent had been to not provide bag mask ventilation to any patients. Matt's prior to SMART provided saline to all of his patients. Those were not choices that we made based on patient characteristics. That was the way we were trained and taught, and that's what we applied to all of our patients, knowing that someone across the street might be doing something completely different. These were arbitrary choices, but patients still experienced all the risk and benefits of those therapies. So half of patients got therapy A, half got therapy B. They experienced all of the benefits and risk of those therapies, but the system learned nothing through that, and care for future patients was not improved. I think we should compare that to risk experienced by patients in a comparative effectiveness trial. The exact same decision has to be made, but instead of being made arbitrarily, the decision is made through randomization. The exact same proportion of patients may get therapy A and therapy B. They may experience the exact same benefits and risk of those therapies, but knowledge is gained from this interaction, and care for future patients is improved. And as I highlighted on the prior slide, when 2 interventions are commonly used in clinical care and neither is known to be superior, having the choice between the 2 made randomly rather than based on arbitrary preference of the treating clinician may represent no more than minimal incremental risk compared to the risk of routine clinical care. I think we've highlighted some of the challenges for conducting emergency care research and why consent is infeasible. I think the question is, how should we conduct randomized controlled trials comparing these standard of care emergency treatments when consent isn't practical? Currently, the regulations allow EFIC and waiver of consent, but there are potential challenges to both. Under EFIC, there's no mechanism to conduct RCTs for conditions that are not immediately life-threatening, like severe agitation, alcohol withdrawal, and the significant cost and time effort required for community consultation and public disclosure make it challenging to conduct low-risk comparative effectiveness research, and the extent of those may be poorly matched to the risk of the research study. For waiver of informed consent, it's unclear how minimal risk should be defined, and in what circumstances a waiver of consent may be an appropriate mechanism for comparative effectiveness research. And I would say that Matt and I are not bioethicists, we're not regulators, and we're not sure which of these should be used most appropriately, but we know that there's an ethical mandate for us to figure this out and for us to conduct more of this research to improve the care for patients. And there are many other people who are writing similar things like this. I'm highlighting here a quote from Ruth Faden, who's a bioethicist from Johns Hopkins, who I think put this point very eloquently and said that insofar as contemporary research ethics and oversight interfere with learning activities that could reduce error and improve clinical effectiveness, the overprotection itself is a source of harm to patients' interest. So I'm going to turn it back over to Matt, who's going to talk about our last challenge for emergency and critical care research.
Yeah, thank you. So in this final brief section, we're addressing what I think everybody has realized at this point, which is to say that it's reasonable to anticipate that different patients might respond differently to the same treatment, and how to address that in clinical trials is an ongoing challenge. Historically, in trials in emergency medicine and critical care, we've often enrolled populations of patients that are heterogeneous in their acute conditions or their comorbidities or their social determinants of health, and yet the way we summarize the trial to implement into practice is by an abstract or a results section that has an average treatment effect. So one summary value for all of that rich complexity in the trial, and we say A is better than B, balanced crystalloids are better than saline, and clinicians internalize that and apply it to future patients, maybe applying some judgment, but only kind of leveraging the overall average effect of the trial and not the rich granularity of its data. As we are moving towards larger trials that better represent the population of patients who actually receive these treatments in practice, I think we understand that the challenge has to be not giving average treatment effects, but analyzing these results in ways that present what the expected treatment effect is for an individual patient. And one way to think about this is that in this rich, diverse group of patients who represent the patients who would receive this intervention in clinical practice outside of the trial, applying advanced approaches to modeling to estimate individual treatment effect and linking those to clinical decision support so that when a provider encounters a new patient, the question is not, is A better than B on average? The question is, for patients like this in the trial, what was the estimate of what the treatment effect would be? Was A a little bit better than B? Was A a lot better than B? Or for a different patient, was B better than A, right? So our balanced crystalloids a little bit better than saline on average, but in sepsis, they're a lot better. But for a 21-year-old with traumatic brain injury, actually saline is the drug that has the best, or the fluid that has the best effect on outcomes. And so that ability to analyze a large and representative trial populations in a way that estimates individual treatment effect and apply that through clinical decision support, I think is hopefully where this is going. This is in its infancy, at least within critical care. We're borrowing from oncology and asthma and other fields that are way ahead of us on this. But I think we're starting to see some of the methods that might eventually lead to this sort of approach in which machine learning, uplift modeling, and other approaches are not focused on what's happening for the average patient or overall. They're focused on how, for an individual patient with an individual patient's characteristics, what is the expected effect of the treatment? And I think you might envision that in the long run, the results of trials, yes, they present an average effect, but they're accompanied by modeling or clinical decision support that says when you meet that next patient, based on all of their characteristics that are in the EHR or the patient enters or the physician enters, what is the expected effect of the outcome for that patient? So kind of reproducible, transparent, reliable estimates of individual treatment effect that are based not on intuition about patients, but on hard data from large clinical trials. So in order to make sure we have plenty of time for discussion, we're going to stop there, and I'll just summarize briefly that in order to generate the comparative effectiveness research that we need to understand which therapies patients are already receiving are beneficial, harmful, or neutral, the therapies that we're giving every day in the ICU and the emergency department, we have to address at least these 4 challenges. The brief therapeutic window in which we might be able to leverage the people and systems of clinical care to conduct a lot of the study procedures. We have to be able to get to sample sizes that can detect meaningful but small treatment effects and noise that is happening in this environment, which will likely involve use of information technology and efficiencies of scale involving the electronic health record, not just for data abstraction, but to facilitate all of the other parts of a trial. For trials that focus on procedures that happen in short time frames with patients who lack capacity, we have to have processes of generating rigorous data to guide the care of those patients. And so the gaps between EFIC and waiver are things that we have to help work to address or work to scale one or both of those current approaches to be able to capture all questions so there aren't things that are unresearchable. And then once we have these big trials that are representative of all the patients who would be cared for in practice, we need to be able to analyze them and deliver the results so that clinicians are certain about the evidence for their patient, not just patients overall. So I think by addressing these and dramatically increasing the amount of comparative effectiveness research, forming the questions that we face every day in emergency, in medicine, and critical care, we hope to over time improve outcomes for patients in this space. So we'll stop there and really want to thank you all for your time and look forward to discussion, but I have to end by thanking the people who supported us in this. So all of the work you heard about today was supported on an NHLBI T32 and the Trans NIH K-12 And John and I are grateful for our K23s, and we'll love to talk about that work at another time. So thank you very much, and look forward to the discussion.
Wow, Matt and John, that was really fantastic, and you covered a lot of territory in in a brief period of time. I think we might have to create a new NIH Collaboratory Grand Rounds Award for that. It was really fantastic.
Talk
Um,
fast.
and I really appreciate you highlighting the challenges, the specific challenges that you face in this work and how you're addressing those. I do want to invite people who, if you have questions, do go ahead and post something in the chat so that I can bring you into the conversation. Until folks do that, I'll ask you a couple of questions that I have. And with apologies for asking about challenges that weren't on your list, I'm going to bring forward a couple of challenges that we experience and see a lot in pragmatic trials, right? So the first, and this came to mind in the context of the fluid management study, right? I think this is right, where you described that there are these commonly used practices, right? And nobody knows which is right. But then I think, John, you alluded to the fact that you might not know which is right, but you know what you were trained to do. And sometimes that training is very deeply ingrained. Talk a little bit about clinician engagement and equipoise when sometimes that deeply ingrained training doesn't feel at all like equipoise.
So I think that's a fantastic question, John. I'll take that first if that's all right. That was the defining challenge of starting up that SMART trial. It was an interesting experience because as an internist who had always ordered saline, I thought the chances that this made any difference were very low. And yet our anesthesiologists and surgeons felt very strongly about it. And so the nice article in New England Journal that first helped define clinical equipoise points out that if one physician feels strongly one way and the other feels strongly the other way, that doesn't mean equipoise doesn't exist. That's almost part of the definition of it. For us, practically, what was really helpful was introducing those physicians to their other perspectives or those providers. So a lot of what we did before the SMART trial was have little get-togethers where we sat the surgeon down with the internist and had them recognize that the other person felt very strongly in the opposite direction. And so breaking those bubbles. So there was a lot of hand-holding, but I was impressed that when we get off in our echo chambers, we cannot even be aware that there's an opposing viewpoint. And people's strength of feeling softened a lot when they saw other relatively smart people who felt the exact opposite.
And I'll say that challenge is easier to address the tighter control you have over the intervention. So in tracheal intubation, intubations in our unit are largely performed by a small group of fellows. And I think that's easy to engage those stakeholders and try to work with them to understand why equipoise exists and why we're doing the trial. I think it's harder when you're embedding a trial in the EHR that's going to interact with thousands of people who they're very hard to approach. So I think that that's an important challenge in every trial, but your ability to overcome that challenge depends a lot on what question you're asking.
That is such an important distinction. Yeah, thank you for that. Let's go to the chat. I wonder if Terrence Wong can unmute and ask his question.
Hi, can you guys hear me?
Minute? Yeah, go ahead.
Awesome talk. I'm a huge fan of your work. Matt, we spoke a couple weeks ago, but we're looking at A lines for the ICU, and my question is regarding how to get nursing buy-in, since our intervention will likely make their lives way harder. I'm meeting with nursing leadership soon, but I was wondering if y'all had any thoughts on how I can navigate this likely challenging conversation. Thank you.
John, I'll swing at that first while you formulate your thoughts. I think you're identifying how broad the range of stakeholders are for these pragmatic trials. We think a lot about patients as stakeholders or community members as stakeholders, but for the conduct of these trials, often key stakeholders are nursing, respiratory therapy, other providers. I think without understanding the details of the arterial line question exactly, I think key piece for getting buy-in is always making sure that whoever you're speaking with understands the importance for their patient. That is to say, I think as healthcare professionals, we are susceptible to hassle bias, where if something makes our lives harder, we're resistant to it. But I think whatever your question is, if the framing for the nursing staff and others is around, here's why this question is important for patients and why knowing the answer to this will improve patient outcomes in the long run, I think because of who healthcare professionals are, that goes a long way. Donuts is the other key. It's those two things.
I'll just say that I think it really, it's a good example of how easy it is to not understand who your stakeholders are until you're ready to implement an intervention, and how multidisciplinary that your stakeholder engagement must be. I think that this is something near to our heart, since most of our work makes someone's life a little harder, and it's certainly easier to do an intervention that makes anyone's life easier. We'll probably never do a trial as popular as the trial that was conducted by one of our colleagues to de-escalate contact precaution. People were very excited about that study because it made their lives easier. But I think for us, it has become a culture change that we engage every stakeholder, and they really have begun to understand the importance of this work, but in part because not only do we engage them in the front end, but we come back to them, to those groups in the back end, and show them how their work resulted in important publications that are changing not just the care for their patients, but the patients across the globe. And that has really led to a culture where within our unit, we've had trials that are not just conducted through, but led by respiratory therapists and nurses. And we really have over time created a culture where there's a lot of engagement and understanding the importance of doing these kinds of trials.
Got it. So basically highlight patient safety as well as bribery with donuts. And hopefully in the future, there'll be a culture change. Got it.
An excellent summary.
Great. Let's go next to Tor Tosteson, who has, I got to admit, the question that was next on my list. So Tor, do you want to take it?
Yeah, let me just try to get, there you go. Hi, thanks for the talk, Ray. We're very interested here in Dartmouth, and actually T and I worked together a little bit, previous question, but we are trying to do this sort of thing. I wonder what your experience has been in terms of finding the outcomes that you want in the, I'm assuming that you're getting it from the EHR entirely. That's sort of our goal. Can we turn this into a learning health system? And part of what we're studying is to what extent is that true? Can we find things? And yeah, but any comments you have on that would be great.
Yeah, I'll take that one first. I'll just say that I think that some of the coolest examples of pragmatic and learning healthcare system trials are those that are embedded in the EHR. But I think your outcome selection will vary based on your question. And we are currently doing trials at the cluster level, the individual level. We're doing trials that are entirely embedded within the EHR and trials that have no connection with the EHR. Our trials of tracheal intubation are completely manual data collection. So in that they're extremely pragmatic trials, but they still use complete manual data entry because that's the best way to answer that specific question. Matt, any other comment?
Yeah, well, I think that's exactly right. And I think the part of what I enjoy most about this work is that understanding how to do the research requires understanding how clinical care works for that question. And so I think we at Vanderbilt especially default to the EHR as the answer for everything. But the answer is there are a lot of ways to embed research within clinical care that have more to do with the people and the systems of care than they do with informatics. And so recognizing where the bottleneck is that you can intervene and flip a switch that affects in very minor ways clinical care. Sometimes that's in the EHR and sometimes it's not. But I think that part of it's very enjoyable because you have to understand the system and how it works, which is often idiosyncratic and is not as straightforward as the EHR. Although if we could do a better job getting every outcome into the EHR, we'd all be very happy with that.
Yeah, just to embellish that a little bit, we focus on that because of the fact that, and we like to cite some statistics, which I really don't have a good reference for, how many things we do in the health system have evidence. And so it seems like we have a mountain ahead of us And so the apparatus of clinical trials, and they're very time consuming. Is there any way to do this other than relying on this system somehow?
So I mean, that's the core issue, right? Is that, and this is what I have started to lose sleep over, is that the mountain of questions that we have that we don't have any data to do, that patients are being exposed to. As we're talking now, patients are being exposed to these therapies and are experiencing the risks and benefits. And so it's this imperative. I say this particularly as the person who gave saline before a trial that showed it might be harmful and who didn't, bag mask ventilate. So it's not like all these questions are neutral or we always end up finding we're right. To me, that moral imperative to not be doing harm with these therapies that we might think are benign because we haven't looked at them is very strong. And so that's the motivator for the need to innovate. And so we don't need to be doing trials. We don't need to be doing things at a scale that's twice as fast, or it's got to be this massive transformation. I think what you mentioned about a learning healthcare system is kind of the root concept. Obviously, the collaboratory, CoreNet, and others are the people who are pushing that vision forward, and we're huge supporters of that.
And I'll just highlight that I think you're exactly right that not only are we not solving the existing comparative effectiveness questions, there are more every day. And COVID-19 has been a time when we've been extremely successful in developing new therapies, and each new therapy leads to several comparative effectiveness questions about whether it's better than existing therapies, better combined with existing therapies. And those differences are certain to be smaller than the differences between that therapy and placebo. And the idea that we can solve each of those questions using the same explanatory trials or similar numbers of patients, I think is naive. And the idea that we can solve those challenges using just post-trial monitoring, I think simply is also a mistake. I think it takes trials an order of magnitude larger to really tell these comparative effectiveness differences. And the methods we're talking about, I think, are the only way you get from where we are now to where you want to be.
Thanks.
Great, thank you. Let's go next to Sarah. Actually, her question really follows nicely on this line of discussion. Sarah?
Hi, can everybody hear me?
Yeah, go ahead.
Okay, great. Thank you for highlighting my question. Yeah, my name's Sarah. Dr. Casey, Dr. Semler, this has been an amazing presentation. Actually, I went to graduate school and I wrote my master's thesis all about comparative effectiveness research, and I'm really a huge proponent of getting pragmatic trials and evidence out there, and that, a lack of evidence shouldn't be cited as evidence against an intervention or evidence for an intervention. And I ended up learning a lot about learning health systems and, taking in evidence as, we're generating so much data every day. And I just want to know how EFIC plays a role in all of that, and how we can be really utilizing learning health systems and all the barriers and challenges in, emergency settings and for research like that. And I had a few other questions, but really that's the central question.
Yeah, I'll take that one. So I'll say that EFIC is an amazing innovation that allows us to do work that could not have been done prior to 1996. It opened up a whole new area of research, and I think they were very forward-thinking and smart in the way they designed many aspects of EFIC, including community consultation and public disclosure, which I think are really valuable. And I think the challenge is that those are really well suited to drug development trials. And the idea that they take 1 to 3 years and $50,000 per site means that by definition, you can't do many of them. And there are dozens of comparative effectiveness questions in every field. And there have been 42 trials of EFIC in the 20 years after it was approved. So I think we either have to come up with a new regulation for minimal risk comparative effectiveness research, like acceptance for it being conducted under waiver, or find ways to bring EFIC down to comparative effectiveness research, to find ways to make it more efficient while keeping those positive aspects that show respect for patients, while still being efficient enough that it can allow these very low risk trials to be conducted without being obstructive.
I think, Sarah, the thing that I would add to John's point is people can conceive of learning healthcare systems differently, and I think it's interesting to see how this is evolving. Our narrow concept at Vanderbilt specifically has been of a system that essentially has three phases. Phase one is observing variation that is not patient-centered. So variation between providers, variation between health hospitals, some sort of variation that is not based on what's known to be best for that patient. That's phase one, is just observing that variation. Phase two is structuring that variation. And a lot of these comparative effectiveness trials are what we see as the structure of that variation. And then phase three is the day you know the result of that trial. Definitionally, to do the trial in the healthcare setting, you build all of the infrastructure you need to implement the results afterward. So we take great joy when we find something that's better for patients, is we don't wait 17 years to implement it. We've already got all the infrastructure. We flip the switch and we can implement that starting the day the trial results are known, at least in the settings that it was conducted, and that's phase three. And so we cut from the talk, but my favorite slides to show are the PREVENT and the saline trial SMART in those three phases, in which our ICU used about 80% saline before the trial, but the other ICUs used a lot more balance. In our ICU, you watch it go from 80% saline to about 50% during the trial. And then before the trial, when the trial was over and before we knew the results, it went back to 80% saline. And then the day we knew the results, we turned the advisor back on and we stocked only with balanced crystalloids. And within a month, and for the 3 years since, we've used almost exclusively balanced crystalloids. So I think that idea, these are not disconnected observational research and implementation science. This is a single linear pathway through which we improve patient outcomes by observing variation, structuring it, and then eliminating it through implementation.
And I think Matt, I lament that we can't show the slide that Matt was talking about, but that's one of my favorite examples when people, they say, well, if there was a difference, we know it already. And I think SMART, we conducted a clinical trial in that setting. We knew in the end that during that trial, the providers who'd only been exposed to saline were now forcibly exposed to both. If they could figure out which one was better by the end of the trial, you would hope they would figure it out. But the day the trial ended, they went back exactly to what their pre-trial practices had been until we published the results and put the advisor back in place to try to influence their behavior.
Yeah, thank you to both of you for answering my questions. And I didn't think I could be more impressed after the presentation, but I am even more impressed, and it's very rewarding what your team is doing. So thank you.
Great, thanks, Sarah. Let's go to Alex next. Alex, are you able to unmute?
Yes. Oh, yes. Hi.
Hey, great. Go ahead.
Thank you. I've talked with both of these folks before, and longtime fan. I'm just curious, we've never had a chance to really talk about whether you've heard objections from patients or families regarding the pragmatic nature of this research, and I'm wondering whether that's come up and what was your response and your institutional response?
So I'll answer part. That's a big enough question that John and I will both have to answer that. So I think the short answer is a lot of our experience, we interact with patients and community members through this research in a different ways in the phases of the research. The phase where we often have the most intense input is in community consultation and community engagement studios beforehand. And so even for trials that are not EFIC trials, we often basically adopt those. So if we are doing research under waiver, we adopt a lot of the same community consultation approaches. And so what we've often heard in those is patients, former critically ill patients, are very surprised to know we haven't already figured this out. That the first 45 minutes of that is always disbelief that we're choosing between therapies that we haven't evaluated. So that's the first phase of that discussion. And there's often some anger and frustration in that phase. The second phase of the discussion is how this research works. And the answer is that there are definitely patients who have objections about research generally, or research under waiver, or research under EFIC. Our experience is it has not been the majority of patients. That in having done a number of these trials now, it's not uncommon in a studio to have one patient or family member who, regardless of the design of the trial, expresses concerns, but that's often in the context of an otherwise very supportive group. And that's been pretty much independent of the trial design. We did a very simple trial of a bougie plastic stylet versus a metal stylet, which patients, and it was the studio was all patients who had been intubated in a critical care or emergency setting. So all of them had received one of those two, and it's a question that none of them would have been asked about. And even in that context, there was one patient who I think expressed reservations about doing research on that topic. But it's our experience, and then obviously we also interact with patients in the context of trials through patient information sheets or for EFIC through patient notification or other things. And with enough description and understanding, our experience has been the vast majority of patients and community members tend to be supportive, but it is not universal. John, I don't know if you'd add to that.
Yeah, I'd just say that there's been a lot published on this out of the EFIC space. So one of the criteria of EFIC requires post-enrollment notification. So you can't get consent before the trial randomization. So you do things like community consultation and public disclosure, which is what Matt's referring to. You also talk to patients after the enrollment and notify them of their enrollment and give them a chance to opt out from continued participation in EFIC. And within EFIC, within trial after trial, they publish the proportion of patients who choose to opt out, and it's shockingly low. So often 0 or 1% of patients. So I think that when you have the opportunity to explain to patients why consent couldn't be obtained, why the research is being done, the proportion of patients who, and particularly in settings where you're comparing two interventions they were likely to get in routine clinical care, I've been, if anything, surprised by the results from our group and other groups about how few patients raise objections to that approach.
Well, thank you. Thanks for the question, Alex. And I'm looking at the clock. It's amazing how an hour just kind of flies by, isn't it? I want to thank John and Matt again for really just an excellent presentation, and consider this an open invitation to come back and present that slide that you didn't get to present this time, because it sounds like a great one and perfect for NIH Collaboratory Grand Round. So we look forward to having you back when you have the next time you're ready to present. It's been a real pleasure. And thanks to everyone for joining us today. I call your attention to next week's schedule, where we'll hear about the best SMU or MSU study, rather. So with that, thanks again, and have a wonderful weekend.
Thank you all.